I'm going to start with Paul. Paul's a rheumatologist in Beaumont, and I'm going to steal one of Kate's questions, or phrases. We need physicians to refer, but belief sometimes get in the way. Why aren't more patients being referred to self-management programs, do you think, Paul?
I think it's a good question, and I think Professor Lorig to some extent answered it herself when she said that doctors are a little bit afraid of the things they don't know that well. And I think part of the issue is that a lot of us as rheumatologists probably don't understand the self-help programs as well as we should. And I mean, the data is out there, but maybe the message just hasn't got out. And I think it's rather similar to information on the internet, that a lot of us maybe have had experience where somebody's come back, they've been put on a very standard medication, then they've looked up a blog somewhere on the internet and bad information has come back to the patient where they wouldn't put anyone on that drug. But I think what we have to recognise is that as doctors we do use information the whole time. When we start somebody on methotrexate or other drugs like that, we give information sheets, and our nurses spend a lot of time educating patients. So I think we are recognising that information is important. We're just a little nervous about making certain our patients get the right information. But I think the self-help programs like Professor Lorig's program here, that Arthritis Ireland have been delivered, has been proven over and over again. We just need to get that message out to rheumatologists more.
Louise is a clinical nurse specialist in rheumatology. Now, putting your nurse's hat on here now, what benefits have you seen your patients derive from these programs? I mean, you've delivered a number of programs.
I have delivered the program, and if I could just add to what sort of the comment in relation to understanding the course, I think. And I was one of the first groups that was trained back 7 years ago, and to be honest, at the beginning I was very sceptical and intrigued sort of about how this is going to work. While I had read about self-management, I was wondering how would it relate into practice, and it's only by delivering the course and seeing sort of how people developed and how they learned, and sort of that lovely reveal at week 6 when you saw how people had progressed through the course, and it just made sense. But until you understand the course, then you can actually encourage people to uptake it. And I think that's probably maybe some of the reason. Just to go back to the question that you asked me in relation to patients, while I'm not partaking in the self-management courses, delivering the self-management courses now, the principles that I've learned, sort of I'm adapting sort of very much into clinical practice. So in relation to, instead of, I allow patients to identify a health issue and to allow them to problem solve and action plan themselves, so to facilitate them and allow them to sort of come to that realisation. So I'm not giving them the information, I'm allowing them to sort of problem solve for themselves. And I suppose that's how it has impacted and how I have developed it in clinical practice.
Okay, Pat, we've all seen the evidence that self-management works. It's good for the patient, it's good for the health system. There is a debate going on about community versus hospital delivered. Where does the HSE stand on all of this? Or can you say?
Yeah, well, I spoke to the the new National Director for Primary Care recently, and he is very conscious of that, and it will be his responsibility along with the National Director for Hospital Care. But what he wants is to get a lot of activity out of hospital. Now that's the manager perspective, getting activity out. Patients or public perspective is, how can I avoid going into hospital and get the best treatment. So I know, was talking to the National Director of Hospitals just to put in place a group to develop an implementation plan to do that. And I know people could be sceptical about that, but actually it's something the HSE just has to do, because we're in serious trouble if we don't. And there's a lot more scope for that. I mean, in Ireland, I think there has been traditionally an overwhelming focus on hospital care, and we are improving, but like our legacy is this view of hospitals almost as the sort of the way cathedrals were viewed in medieval times for a particular city, that you had to have this wonderful edifice which testified to the the value and the importance of the city. So I think we're getting away from that. We've had a lot of public debates about it. So I think it should actually be a bit easier than it would have been in the past. I think it will happen. And incidentally, I did speak to John Hennessy, who's the National Director for Primary Care, about embedding self-management in that when we do it. And he says he's quite willing to do that. I mean,
well, it's certainly part of the rheumatology programme.
Yeah.
We're on that, and because there's a lot of evidence base there. I mean, clearly we need to have it in every chronic disease programme.
Yeah, and I mentioned money there, but I actually don't think that is the issue, to be honest. Although, like, I think there's been a massive unstructured downsizing of the health services. But one of the issues is I think that a lot of managers have just been given so many priorities and urgent priorities that, like, it's hard to get something on their agenda at times. But I mean, that's not an excuse. I think that there are people like John Hayes here who are actually doing it. I think, you know, I'm always encouraged by that when you have a group of people who are doing it. That says it can be done.
I mean, obviously the emphasis is on cost cutting at the moment. I mean, is there an appetite for the whole return on investment model? You pay €1 and you get 5 or 6 back?
I think there is. There's also a new health and wellbeing directorate, which I work in now, a new national director there, and I think she's going to be more active in working with some of the other national directors on these issues.
Okay, we're going to take somebody in from the audience just to join in.
Just to follow up on that, I'm a primary care manager in Cork, not especially for it. I'm not a patient therapist. A couple of the challenges are each of the disciplines has specialised. I'm specialised in arthritis, and I've tried to run self-management groups in a small primary care team. We don't get enough referrals because there's enough of one group of people. The dietitians have taken on diabetes and physios are doing cardiac. So I'm really interested to go back now with the fact that we should pool our groups in our primary care teams and work together. It never occurred to me because we all have probably over-specialised. So that's a big challenge, is for us to go back with a new model, and certainly it fits very nicely into primary care where we're bringing people out. I don't think it's possible for hospital staff to run these in any great bulk, but we certainly within primary care have skills and have local communities, and what we're looking for now is really to upskill ourselves. We have to run them with the new model of coming together with different groups of patients. So I'm excited to see how we can do it.
Thanks for that. Can we open it up again here? Just while the mic's working, that's way over. Claire, I like the expression, the patient should stop being the ball. Would you like to
I loved it really, you know, and I suppose I remember in the beginning feeling, because I wanted to put effort, the typical teacher, you wanted the correct resource books and everything like that, but in a way, for the first 10 years, in a way you were a little bit discouraged from doing that. And so I do feel it is important that those messages come at patients from all sides, you know, and I certainly liked that my GP was telling me that I would be able to manage it. I liked the positive messages that I was getting from the healthcare team. I liked that they were being frank and telling me, yes, it's a serious condition and stuff like that. But I really do feel that it would be lovely if every health professional you ever met told you, you know what, you can actually really improve your life if you know, do something in a structured way, you know. So I love the analogy. It's great.
I'm conscious we've flown Kate 6,000 miles to be here, so I'd love if one of the questions was maybe directed at Kate. Do you have a question for Kate before we fly her back? Go ahead.
It's not actually originally directed to you, but you know, it could be broadened to that. I took part in one of these courses, and it made an enormous difference to me. And I'm somebody who spent all my working life in a hospital, in a laboratory, so you know, I could see the difference. What I really found particularly good was that the group was kind, imaginative, working on absolute halfpence, and it was culturally sensitive. And that's something which a lot of things which come through to us from other aspects of life are not. And I just wanted to get some feedback about your approach to the whole wide spectrum of what hits people, from this thing called Operation Transformation to try and help people lose weight, but I think it's very disrespectful and actually quite bullying, and I think it's short term. While there was some other series on TG Carr, the Irish language one, called Traum Patrim. I don't know if anybody saw it, but it was absolutely superb and made on a shoestring and completely the opposite of bullying. So just if you have to deal with a whole range of cultures, languages, economic, absolute horrors in the States when it comes to healthcare, maybe it might ring a few bells with you.
I reckon that is one for Kate.
Isn't it?
Yeah.
Our programs are very much what we call self-tailored. Self-tailored means that we don't tell people what to do. If you really come to the classes and see the classes, at no point do we ever tell an individual what to do. What we do is we tell people what we know about exercise for people with arthritis, what we know about cognitive therapies for people with arthritis, and then we give them a structure that they can choose what they want to try. It's a lot of self-experimentation. Safe self-experimentation, by the way. We work really hard to be sure that it's safe. But the reason that it's culturally sensitive is because the leaders come from the culture of the people that are offering it. And I often make this example. At Stanford, one of our leaders will be a Nobel laureate, because I come from a very erudite culture when it talks to about our faculty. And 20 miles away in our Spanish community, our leaders will be somebody that does not speak English. So the leaders make the course, the venue makes the course culturally, and then the other thing that makes it culturally sensitive is that people make their own decisions what to do and are supported to do those within their own cultural context. I don't know if that makes some sense. So it's not that I try to make this culturally sensitive. There are few cultural adaptations, and you're going to be surprised at what they are, because we're now in 30 different countries, so we do a lot of different stuff. The cultural adaptations are food. Food is different everywhere. Secondly, was one that surprised me, and my guess is you would not guess. It's prayer. Some cultures pray, some cultures don't pray. And either one, to do or not do, would be culturally inappropriate. And so whether people pray or not pray with the classes is up to wherever they happen to be. And the third happens to be exercise. For the United States, for most of Western Europe, exercise is pretty standardized. But for many of the Asian countries, the exercise routines are different.
Grainne, you're in the middle there. The volunteering aspect of this is really important. Do you want to explain our experience with recruiting volunteers through self-management courses?
Yeah, I mean, we've had, I suppose, a phenomenal success, and I'm looking out to the audience here and I see many of the people who have become active volunteers. As you've heard more than once today, we've delivered the course to over 3,500 people, and we have found that it's the biggest recruitment ground for us in terms of people who've had such a positive experience with the program. They want to give back. They want to be in a position where they want to help other people, so they may train themselves as a leader. And there's many of you here today who did that. You did the course and then you found it so beneficial personally that you wanted to give that back to other people, so you trained as leaders. Secondly, we have a branch network who are all volunteers all around the country. We have 22 branches, and many of the volunteers in those branches have come from the self-management programs as well. And not only do they obviously give their time as volunteers to providing services to people with arthritis in their local communities, but they're also very knowledgeable about self-management and about living with their arthritis as a result of doing the course. So they bring just such a huge added value to our branch network. And I suppose the other area would be our helpline. We started a national helpline 4 years ago, and all of the 30 volunteers who come in every single week are all people who've done the self-management programme, and many of them featured in the report that you have in your hands today. So that's just a testimony to if you like, the additional benefits that the programme has brought to us as an organisation, and might be interesting for some of you in the audience that come from other NGOs as well.
Yeah, excellent. That's great. Paul?
Could I just make one or two points? I've spoken to a couple of patients who have gone through the programme as to what they thought was the most useful things out of it. And I remember one patient who told me two things that I thought was very interesting. The first was she felt that she got a lot in terms of self-management, what she could do, and that she felt that if she was having a flare, it gave her permission to ask her doctor about certain things that she could do, but also things she could do herself. The other thing that she said was that she felt that she got much more out of her doctor's visits because she was much more prepared for them, that she had a goal for each visit, that, in other words, she was taking a bit of a charge, but she wasn't coming to me to sort of say, well, you know, or to our team to say, well, what can I do for you? She had, well, you know, I've got problems with this, and she'd have her list. And she felt that she was much more in charge of the visits from that point of view, that it made a difference to her. I think this comes back to your whole concept of self-efficacy, which is so important. And there's no doubt that it made her a much more productive patient, in the sense that it gave her much more of a crown. And in a sense, you know, she was part of the team and no longer the ball. And so I think that aspect of it is very important from those two things, what they can do for themselves, but also they also felt that she was able to use the health professionals better and to gain from them. And I think those two things are very important. And from the HSE's point of view, I think these programs are great bang for the buck. They're largely delivered by people in their own time and non-professionals that they're not paying. So in terms of bang for the buck for what the HSE is getting out of it, I think that they're great programs.
Yeah, I actually have a suggestion for an HSE study, which has never been done, but you might be able to do it. I actually have a theory that you're getting a whole lot more out of it than you think you are, because all you ever evaluate is the people in the classes. And you have all these volunteers in the communities that are talking to their friends and neighbors every day. And I think there's an added value somewhere there. I don't know how to capture it, but you're really adding to the health knowledge or the health literacy of the community, not just the individual. So I would love to see that.
We'll help set that up for you, Paul. I didn't set that up, by the way. So.
No, I had not even thought about it.
We're going to ask just a couple more questions because we have some time pressure. Yeah.
I just want to say it is through the Arthritis Ireland and the self-management course, but I would say my confidence has grown in knowledge of the disease to the extent that myself and others here are giving a program to the student medics in UCD. And I think people talked about the change in beliefs of the physicians. And I think that would be an excellent place, it's more of a comment than a question, an excellent place to start on the change of belief in physicians, because we're meeting them when they're 17, 18, and going on to become doctors and consultants. And we find the feedback is so positive, absolutely so positive. Instead of getting a case study and pretending they have an illness, they're actually meeting people with the illness. So I am so grateful to the course that you have developed. I am so grateful that I am part of it. I can't even start to say how much I've got from it.
At the back, and then gentleman in the red.
Sorry, John, could I just add to that, and you know, to just maybe it would be worth considering maybe rolling that course out to, you know, other members of the multidisciplinary team, sort of, you know, nursing staff, because, you know, when you come to your rheumatology unit, you not only see your medic, but you see your physiotherapist, your occupational therapist. So, you know, to sort of increase that exposure to the whole multidisciplinary team, so therefore they know, you know, what the whole principle of self-management is, because I think that's sort of some of the problem. People aren't really sure.
Patient is playing a strong part.
Yeah, so just maybe, you know, to start with the physicians, but maybe think of the other members of the team.
Good question down the back.
Yeah, I'm just curious how you would target that kind of hard-to-reach audience. I know from our team in Hearts Cross we work very hard in terms of advocating for self-management and encouraging people, but there's always a cohort of people there who there are various barriers, be they high levels of anxiety, be they literacy, be they social, demographic, you know, cost factors, childcare, all of those. And I just wonder if there are any new initiatives you can grow on your case in particular, Claire, that you we can help to reach the hard to target audience, because we obviously see the benefits in the patients who do go, and especially the peer support.
Yeah. We actually in our country very often talk about the hardly reached. I think to reach those populations, you really have to understand where they are and go to them. And this sounds very strange, but all of those hard to reach populations are somewhere. We just did, for example, a whole study in the mental health centers for the community mental health centers for the severely mentally ill in the state of Michigan. And those are not folks that are ever going to come to any of our other classes. We do courses in garages in the Hispanic community. We do courses on the night shift for shift workers in factories. We've actually given courses that ran from 4 a.m. to 6 a.m. And so a lot of it is just figuring out where those folks are, because they're somewhere, and what their community is, and one way or another getting into that community. And that's not always comfortable. I will tell you, it's not always comfortable, because it's not where we are. And I'll give you just one little tiny story, and that was that several years ago, on Easter Sunday, I gave announcements about our classes 3 times at Spanish masses. I speak Spanish. And that wouldn't be too unusual, except for the fact that I'm Jewish. And I tell you that story because giving those announcements in my synagogue would not have reached that population. That's what it takes. So, does that make any sense?
Yeah, we're going to have just one question here, and then we're going to do one more, because we're under a lot of time pressure. Okay.
John is our area manager in Donegal. We've been running this program for I think 2 years now. First of all, I think the experience that we've had is that the generic program works very well, because we do have some illness-specific programs in addition to that, and we give people the option of doing it. From a national point of view within the HSE, I suppose what I'd be looking for is a strong endorsement, leadership and direction, because that's actually as important as the money initially. And a lot of these programs are, and our experience is, that you can tap into the resources in the community, and that becomes self-sustaining in its own way. And the more the community, those organisations take ownership of these initiatives, the more they get embedded in the community. And also they assist in terms of facilitating access, because the people involved in the local areas have more knowledge of the people who are going to benefit from these programs than me as a manager in the system, if you like. So I think that our experience is, both in the primary care generally and in running these programs, the more we get community engagement, the more successful they are. I would be interested a bit more in hearing about the online opportunities, because that's probably something that I might have been a bit skeptical about, just in terms of the potential there in doing this and having the same benefits. Intuitively, to me, it's sort of, I would need to be convinced, and I'm not sure if there are some cultural differences between the United States and Ireland that makes me skeptical there, but I'm open to persuasion, if you like, on it. And I suppose the other
Sorry, can I just stop you there, because we need to move on a little bit, but that is an interesting point about the online. I mean, surely online transcends all sorts of cultures and borders, and as you said, Kate, there's some good evidence there?
Yeah, we actually have evidence of the online now from the United States, from Canada, from England, and from Australia. So we have studies from all those countries. Now, it may very well be that the culture is different, and I certainly hear your skepticism, because quite frankly, the skepticism is always the same. What I would urge is that if a few of you, especially those of you that are skeptical but maybe in a policy point of view, would like to see the online program, if you would send me an email, I will see if I can get you to be a participant in some of the programs in the United States. Because I think it's kind of like the self-management course, you have to see it. And I'd rather than my talking about it, I'd really like you to see it. So there's two ways of seeing it. Number one, a few of you I could probably get into a course. We've actually licensed the course to our National Council on Aging, which is a non-governmental agency, and they're really running the programs. I'm not, so that's why I say I can get you in. So I could probably get a few people in. The other is, if there was enough interest, we could probably do a online demonstration of the program for you. I mean, the nice thing about online is I can sit in my office at Stanford, you can sit in your offices wherever you are, and we can do a demonstration. So if that's of interest,
oh, absolutely. Yeah.
Let me know.
Yeah, and some of them online is a solution.
But I think you have to see it, and I understand your skepticism, because I was the biggest skeptic of all. My staff talked me into this.
Okay, we're going to take one more question and then let everybody go.
Hi, my question is for Kate. Actually, I work for the Alzheimer's Society of Ireland, and I'm just wondering, have you had any experience or know of any studies around self-management being used for people with dementia, early stage dementia, and
I'm sorry, being with what?
have you any experience
With dementia?
Yeah.
Self-management
For dementia. Not for people with dementia, but we do have a program for carers of people with cognitive disabilities, with dementia. So we do have a program for the carers, but not for people with dementia itself. We did work with the Alzheimer's Association in the United States a couple of years ago, and they determined with people with mild dementia did fine in the self-management programs and seemed to benefit from them. We don't have evidence that this was just kind of anecdotal, as long as you don't do a whole course of people with dementia. But if somebody with mild dementia and their carer comes to one of these courses, it seems to have been beneficial. It did not seem to be harmful to the other people in the course. But they actually recommended against doing a course for all people with dementia. And if you're really interested in that, I could probably get you that report from the National Alzheimer's Association in the States.
Okay, thanks, Kate. I'm afraid we're going to have to pull the plug. Just before we all go, can I thank collectively the panel for all the work they've done today. Just to say that please take a copy of the report on the way out, read it, and please recommend all your friends, family, neighbours who have arthritis that you think could benefit from the arthritis self-management.
Copy of the slides from today.
I'll talk to you about that. Yeah. Thanks very much and safe home.